I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
While the panel is coming up to the podium here, I'd like to remind individuals that there have been, it is difficult at times to get access to microphones, so I'd like to remind you that the panel will be reading these comment cards, and if you would like to submit those in terms of questions or comments, please do so. I've received a number so far. I'd like to open the discussion with the panel and ask questions, have the panel ask some questions. I know that some of the panelists have some questions they'd like to address to some of the speakers yesterday afternoon that we did not get a chance to do that. Dr. Weissman.
Questions to Mrs. Gregson. Is she in the audience?
Yes, right here.
Yes. You mentioned yesterday in your presentation that you had 100 ECT treatments. Could you tell us something about what your diagnosis or your problems were, whether alternate treatments were received and whether they failed or were considered, and whether these treatments were voluntary or involuntary?
In 25 words or less, right? Over a nearly 10-year period, I was treated with every psychoactive drug that was available, antidepressants, what's called major tranquilizers, sleeping pills. I was in private hospitals, I was in public hospitals. I had a variety of diagnoses I have been able to find out. It ranged from depression to anxiety to schizophrenia to affective schizophrenia and a variety of other arcane terms in between. I was, to use your terminology, suicidal. I attempted suicide a number of times. My own 20/20 hindsight says that I had serious emotional problems. I had problems in living, which were never addressed. And in fact, the continuing series of electroshocks that I received made it over a 10-year period more and more difficult for me to deal with those problems. It wasn't until after I severed all relationship with psychiatry, with drugs, and with shock in 1971 that I was able to get control over my life and to resume a normal life. I was what is known in the lingo as treatment resistant, which means I was fair game for anything that came around.
How do you feel that your suicidal problem should have been handled? What would have been the best treatment you feel you could have gotten, if any?
This may be difficult for people to accept. There was a question yesterday, perhaps I was not asked it. Dr. Austin was asked it, and he very wisely said it was not within his realm. He was posited the situation of a suicidal person who would not, I don't exactly remember the details, would not take medication and would not go into the hospital and was intent upon committing suicide. The assumption of the scenario was that this person might, in fact, commit suicide. I've thought long and hard about this. I have children of my own, and I have come to the conclusion that it is more moral, it is more acceptable in a free society not to impose intrusive and dangerous procedures like ECT and involuntary commitment on people. And if in fact there are casualties, which very likely there would be, they would be far fewer than the casualties that result from involuntary psychiatric treatments in this country. Which is not to say that you stay your hand when someone's on the windowsill, so to speak. I never received in all my years of psychiatric involvement in my life the kind of caring that Dr. Reagan spoke about yesterday, the kind of involvement, the kind of reaching out that Judy Chamberlain spoke about yesterday. And if it sounds naive and it sounds simplistic, it's nonetheless my feeling that people who are suicidal are people who are desperately troubled, are people who are desperately isolated, and the best that you can do for them is to give them the kind of care and the kind of love and the kind of reaching out that we don't get in mental hospitals in this country.
Thank you. Dr. Lubnick?
Yes, I have. Seem to be having this problem with two microphones. I appreciate everything you say, and I think part of my job as a neutral panelist who really doesn't deal with people who have severe depression. I'm a little puzzled about one thing. And that is, I'm hearing two sides. I'm hearing your side, I'm hearing people who have had ECT and think it's wonderful. I'm not clear about your position. Are you saying that no one in this country should have ECT, or are you simply saying that people who do not give informed consent should not have ECT? What would you tell a person who wanted to have ECT?
You just asked my question. You just gave my comments. I think it's an issue that wasn't touched on this morning, and it's very, very crucial. Two things have come out of the presentations yesterday and this morning, and I'd like to deal with them briefly and answer your question in the process. It would be foolish, it would be silly, it would be bizarre for me to say that people who stand up here and tell you that they have been helped by ECT have in fact not been helped by ECT. I feel that we have to accept their accounts as much as you accept our accounts. In fact, though, what seems to have emerged, or what I hope has emerged and penetrated your consciousness is that although you may find people who say that they were helped by ECT, and in fact you have to accept that this is their experience, you also have to be aware that we are not voices in the wilderness. We are not oddities. We are in fact representative of large numbers of people who have been harmed by ECT. So the crucial issue, or one of the crucial issues that you must address yourselves to, is how pervasive is this damage? How widespread is this memory loss? And what in fact are we talking about when we're talking about memory loss? Are we talking about people who can only not quite remember who the doctor was who gave them shock treatments? Or are we talking about people who lose all of their professional training and can't go on with their careers? There are people in this audience like that. Are we talking about people whose life experiences have been wiped out? We can't remember the names and faces of their neighbors. In fact, what I'm saying is that the question of damage from ECT is the crucial issue that you must put your attention to. And in fact, as Dr. Freeman pointed out kind of peripherally, this is an issue that has not been explored. I feel that it is incumbent upon this panel, and making policy in a sense, which is what you're doing, to come up with some mechanisms, unwieldy though they may be, by which the population of this country can be asked to come forth and speak, whether it's in small town meetings, whether it's in central, northeastern, western editions.
Could you finish up, please?
Yes, I will. I'm answering the question.
I'm trying to keep the 2 minutes.
I understand. I guess that answers your question. The other aspect of it is, what would I tell someone who's going to have ECT? I would feel that part of informed consent, they must be informed that it is a highly controversial treatment, that it is a treatment from which they are very likely to suffer memory loss, from which they are highly likely to suffer some kind of loss of intellectual function. And if that means that many of them will say no, so be it, because that's the state of our knowledge, and that is true, so they are entitled, at the very least, to truth.
Thank you. Dr. Silver?
Dr. Roth, in this morning's presentation on informing the families and also the patient through videotape information of the ECT process. You described it.
Well, let me say, first of all, the videotape work we did was myself talking with the patient, educating the patient to capture the whole consent process for purpose of study. We did not use videotapes informing patients about ECT. Baxter and his colleagues, in a very brief publication that Jack Blaine sent me, it's an oral presentation, said that they showed a videotape about ECT to a patient and compared the oral explanation with videotape explanations, and they found no difference. I have read and critiqued, really, more than 130 studies in informed consent. There are no studies that convincingly show that videotape education is preferable to one-to-one discussions. However, it may be a useful procedure with some patients. I think Barbara has a paper in this area, and I can refer you to the literature. I think the most important aspect about information is that one must be creative and take an individualized approach. Some people, quite intelligent people with very good backgrounds, used to reading consent documents, do great with consent documents. So some people, consent documents are like deeds. They have the same reaction that you and I have when you see a deed or a legal contract, which is gobbledygook. Those people, of course, are going to profit more from oral disclosure. Some patients, to know about psychiatric hospitalization, should be taken up to psychiatric wards to see what's going on in that ward before they admit themselves. That's experiential consent. In the studies we do on research, I feel the critical element of disclosure in research is not only prior disclosure, but continuing disclosure about the aims, purposes, and objectives of research. People have a hard time understanding randomization. I could go on and on. But basically, that's...
I'm sorry. Please come. Would like to answer your question, Dr. Clayton, please.
Can't hear you. Can't hear. You're not speaking into the mic.
Yes, I didn't have a great deal of time to go into it.
The ETC
Score.
it was, you were asked before, and then I guess you were asked again if you remember. My question is, did you do any follow-up? Did those patients who did better on that score remember that after their course of ECT? Because it seems to me that's a critical issue.
Well, the answer is no. I did not follow these people's level of understanding in a sequential basis. I would anticipate that it probably goes down. That has been studied, frankly, in all areas of informed consent because people forget some of the details. Ethically, to me, the critical question is whether the patient understood prior to the treatment, not after the treatment. After the treatment has something to do with compliance and satisfaction, and may be extremely important. But the critical question is, did they understand before the treatment?
Mr. Berg.
Speaking to the mic. Can't hear.
Now is this good? Two questions that I'd like to put to you. I'm very sympathetic with your view that setting process should be thought of as a process and not as an event. I think that's a powerful proposition. How do you address this concern, though? Concern that arises from the fact that the discussion takes place between a physician or medical personnel who believe that ECT is something that the patient should ultimately think is a good idea. How is it that one can, just simply in that context, achieve the kind of neutral provision of information, of acquainting the patient with risks and benefits, of making sure that the patient is in fact making an autonomous choice? That's question one. But when you've addressed that, I have another thought that I would like to
talking about a central problem in medical ethics, unequal positions, bargaining power, and information between physicians and patients who are inherently one down. I feel that first of all, it's a matter of self-scrutiny. Can one objectively look at the data and present, for example, Dr. Squire's data? I think that Dr. Squire's data condensed is a relevant piece of information for patients to have. I think that one inevitably is an advocate for treatment, and I try to divide myself to the extent possible between this is what is known objectively and this is what I believe. Many patients, after you go through the whole thing, look at you and say, but doctor, what do you recommend? And I say, I'll be glad to tell you what I recommend because that's what we're doing here together. I don't feel it's illegitimate for people to advocate for treatments. That is the service that the patients presumably are coming for. But inevitably, no perfect bargain exists.
Oh, but could you help us to think systemically? I mean, I hear what it is that you say that you do to address this problem.
How would I institutionalize this?
Yes, that's right. So
I'm not a great lover of bureaucracies, to be truthful with you. One way I would institutionalize it is through the education of medical students, which I think is progressively occurring about patients' rights, through the types of physicians that we train. There are, of course, numerous other mechanisms. There are ombudsmen, there are patient advocates, there are review committees. One can come to a number of mechanisms, but frankly, I've seen all of those corrupted. I'm not against any of them if they're given empirical trials, but there is no substitute for a caring physician who honestly tells the patient what he believes, and that's the way it is.
I'll ask one other brief question along these same lines. Have you thought about the possibility of ECT treatment, particularly, of in effect dividing the consenting process up or repeating it, if you will, over and over again, so that one is not simply talking about consent at the beginning of the regime that ends the consenting process for all time, but rather repeats it at the
Well, empirically, I'm not a physician. I don't give ECT, but I have studied the process and watched these patients sequentially. That already goes on to some extent because some patients, after having received 2, 3, 5 treatments, as alluded to by Mr. Parry, no longer want treatment. And if they are competent, they have the right to refuse that treatment. Therefore, there is a re-education process that can and sometimes does occur.
That depends on them taking the initiative.
I think in general, the principle of repeated consent information being given over time is an invaluable one and cannot be avoided. In my own research, and I had to get consent for my research from questionably competent people. What we did and that was a whole other issue. And eventually we went back and got retrospective consent for the videos from the patients who were most disturbed. It's important to give the patient the consent form, which I did for the research, let them study it for a day, and then I came back a day later to see whether they wanted to participate. That's that same principle.
Dr. Janowski and then Mr. Levin. Can we try to have all the microphones turned on at the podium, please, and save a little time, which is seems to move most pressures come on me.
Well, since I was the one that brought up the hypothetical case yesterday, I wanted to reiterate it and get your opinion, or any of the people who feel been patients and been treated with ECT. The basic concept was that an individual had been treated with drugs voluntarily. He was a voluntary individual. He hated the idea of being in the hospital, thereby said, if you put me in a hospital, I'll kill myself. He wanted to get better. He realized that he had depression. And he also felt so depressed that he would kill himself, or thought he would probably kill himself and wanted help. And then the question came up, should he have ECT voluntarily? And what should you tell him? And the real question I'm asking, I mean, this is a real case, okay? This isn't, off the top of my head. The question in my mind would be, do the people who've been patients and who've suffered from, or feel they've suffered from ECT or did suffer, feel that indeed there should be a ban on ECT ECT under those circumstances where a person voluntarily would consider it and receive complete informed consent. Look, you can have this, and your memory may go, your brain may be damaged, assuming that's at least a small possibility, etc. And I'm curious to know the extreme, because in Berkeley, obviously, the people voted to ban it. And I'm curious to know sort of the consensus feeling of people who feel that ECT isn't good for you or that it's hurt them. If under the circumstances of fully informed consent and voluntary submission to ECT, if that's an acceptable treatment, or in fact that should not be at all in the armamentarium of doctors or the treatment.
Dr. Nasty, are you addressing that to anyone in particular?
I'm asking it of any of the people that would speak to the anti-position yesterday. The woman who spoke just a minute ago would be one person, but I noticed there's two others in the back of her that have similar attitudes about the matter.
My personal preference would be to say that it's an unacceptable treatment. My sense of fairness would say that if it were possible to go along with the guidelines that you're suggesting, and if it were possible to give true informed consent with complete knowledge, then I guess people should have a right to avail themselves of this. It goes against all of my experience and a good deal of myself, but there's a certain part of me that would say, I suppose it should be available under those circumstances. The person you're describing, who hates being in hospital and had those experiences, is not a likely person to want to undergo ECT.
Ms. Scott, I wonder if briefly either the two speakers behind you would like to comment about that specific question from Dr. Janowski.
Yes, I think the key question is whether or not ECT is legitimate medical treatment. I have no right to walk into the doctor's office and say, "Doctor, cut off my arm." And the doctor has no obligation to follow my instructions, even though I've consented to this. And I think the key issue will be that sometime in the future, I don't know when, but sometime in the future, we will look back on ECT the way we look back on most of the other discredited tortures that are committed on mental patients who may be treated.
Mr. Frank?
Another key issue would be the possibility of whether informed consent for ECT is conceivable in a psychiatric facility or even outside of a psychiatric facility. But so long as there is the possibility of involuntary commitment, there is always the pressure and threat on the individual that if he refuses to comply with the doctor's suggestions or wishes, that he will be locked up. And that is the greatest danger. And we feel, especially in Berkeley, there were a number of us who were active in the campaign against electroshock, who felt that because of our own experience and because of the many things that we've heard about people being locked up, that it was just inconceivable that there be informed consent. We didn't like the idea of having the government intervene, but the government is already involved in the use of electroshock because the government allows psychiatrists to lock people up and to put them in situations where they can, where they have no chance at all of refusing treatment.
Thank you.
Also, in Berkeley, it might be pointed out, we were talking yesterday about the isolated cases of a few number who have stepped forward. There are many, many people who have had shock treatment who feel very, very strongly on these issues. And when we had public hearings in Berkeley that were announced long in advance, there were about 45 people who testified. There were only 3 people speaking against electroshock. They were all part of the psychiatric, in favor of electroshock. They were all part of the psychiatric establishment. But there were 41 or 42 individuals, many of them mental health professionals, but the majority of them were people who have experienced electroshock. And if you had heard those reports of what had happened to them, the circumstances under which the shock treatment had been given to them, the memory loss that they suffered, the brain damage.
Mr. Frank, in terms of fairness, other questions, I think you expressed your opinion about Dr. Janowski's question about what you would do, and I appreciate that. I'm sorry I can't let you go on in terms of other panelists having questions. Mr. Levin. 2 quick questions for Dr. Roth. First, could you review rapidly those aspects of the informed consent process that you feel are or should be unique to ECT treatment?
Well, I mean, conceptually, I don't think there's anything that's unique to ECT treatment. By that, I mean the nature of what is to be done, standard portions of the legal document, the nature of the procedure. In general terms, the purpose of the procedure. The benefits to be achieved, their probabilities, the risks to be undergone, their probabilities. But most importantly, and completely ignored in consent forms, the alternatives. The central rationale of the informed consent doctrine is to permit the patient to be the decision maker about the risk-benefit ratio. Because it is balancing the risks and benefits where the patient's values come into play. To give you a concrete example, I can foresee a day in an institution that would do both unilateral and bilateral treatment, where the choice of unilateral versus bilateral treatment should be the patient's and not the doctor's. Now that would depend if there was a difference in efficacy, supposing it was shown, and some people argue, that bilateral treatment was more efficacious. It also induced more side effects. That is not a medical decision as to whether bilateral or unilateral treatment is given, assuming that both meet a certain professional standard of adequacy. So that the patient must know the alternatives, not only within the types of ECT, but compared to no treatment. And traditionally we talk about the risks of no treatment, the likelihood of suicide, continuing despair, inability to leave the institution, and what have you. And good alternatives of continuing drug treatment. Most people present informed consent after the fact. Our studies show that the informed consent form is given after the decision is made. Therefore, it's irrelevant. That's not the issue. The alternatives have to be presented up front.
Thank you. Second quick question. Would it appear appropriate from your studies to provide patients, potential patients, families, with basic information that would be universally accepted? That is a kind of fact sheet comparable to a package stuffer.
Yes, I believe that an information booklet, NIH may have some good.
Are you finished with your question, Dr. Mr. Okay, go on.
NIH may have a booklet on this, I'm not certain. I think information booklets that people can take home with them and read at leisure, not within the boundaries of having to sign, are important. I should make one final comment that is a paradox that goes back to Mr. Burt's question. There's a reciprocal relationship between information and voluntariness. You can't get away from it conceptually. The more time that is spent with the patient, the more information is given, the more the doctor is reasonable, the more the sense of social obligation grows between doctor and patient, the result of consent. And that's why, eventually, most people consent.
Are there any other questions from the panel? Dr. Anderson.
I wonder from all the speakers what you would recommend about ongoing consent that goes on between affective episodes, given that the people who are most likely to get ECT have recurrent illness, what you would advise clinicians to do on an ongoing basis about making informed decisions about what treatment they should get if they should get incapacitated in the future.
You're talking about the situation each different ECT treatment?
No, I'm talking about after the person left the hospital, the person may have an ongoing illness. In other words, recurrent, by and large, is a recurrent illness that come back. The person may well find himself in the same situation again. So you're in a position where you can inform somebody when they're well, when their cognitive functioning is normal. You can give them much better and much more ongoing, truly informed consent, presumably. You can also allow them to make decisions about what kind of care they would like to receive if and when they get sick again.
I agree.
But do you have any experience? We have the task of the practicalities of doing this.
Now I look at it more from a legal standpoint. I'm not in a hospital situation. I'm not dealing with clients in a legal capacity either. So that I think that the important consideration is the quality of information, and I think you can provide that information in the least threatening situation in which the patient and the doctor and family can make the most reasoned their decision not to self-regulate cannabis.
Could I ask you about that recently? It's actually quite common practice in the UK to have a situation, as you described, where a patient gives informed consent in advance of their next illness. And I think providing that is done with a relative present as well, or a member of the family present, that's a very valid procedure. The patient to say, doctor, if I get ill again, I want you to treat me at that time. You still have to go to the same consent procedure at the time of the illness. But I think, for example, if you're going to a report, which we have to do our company sometimes, to have that statement from the patient when they're well and rational is very important. The second point about the continuous consent procedures, we now have a system in the UK, a recommended 4 ECT forms used by the Royal College, where each pair of treatments has to be prescribed. You can no longer prescribe a course of treatment. It doesn't mean going back to the patient each time getting informed consent. It means reviewing with the patient whether they want to continue with treatment. In our own hospital, we've expanded that to every single treatment. You can only write the treatment for that day, and you have to see the patient within 24 hours and explain to them again what's going to happen before they enroll in the course.
Thank you. I think I'd like to go on now to ask just a few questions before the resumption of the formal presentation. Sir, I think you're...
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320 some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer used to hit an amp. But I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but that is the point. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it. That's right. Just bite down. Now bite down on it.
good. Are you ready? Here we go.